Good morning. I'm Eric Linzer, President and CEO of the New York Health Plan Association. I want to welcome you all to day one of HPA's annual conference. How do we ensure innovation is accessible to all? Thank you for taking the time to join us. We're excited about the speakers and panelists who will be with us today. And our sessions will examine the healthcare outlook beyond COVID-19, as well as the role of technology post-pandemic. We're also extremely excited to have and honored to have Senate Majority Leader Andrea Stewart-Cousins to help us kick off today's program. Elected in 2006, the Senate Majority Leader represents Greenburgh, Scarsdale, and parts of White Plains, New Rochelle, and Yonkers in the New York State Senate. In 2012, she became the first woman, an African-American woman, to lead a New York State Legislative Conference. In 2019, she shattered the glass ceiling when her peers elected her temporary president and majority leader of the state Senate. Born and raised in New York, she earned her Bachelor of Science degree from Pace University and her teaching credentials in business education from Lehman College. In 2008, she earned her Master's of Public Administration from Pace University and is a proud member of Pi Alpha Alpha, a public administration honor society. Now, before entering public service, Senate Majority Leader Stewart-Cousins worked in a variety of professions, including customer service, sales and marketing with New York Telephone AT&T, journalism, personnel, and as a teacher for Yonkers Public Schools. Senate Majority Leader Andrea Stewart-Cousins has been honored with hundreds of recognitions and awards due to her extensive legislative work and community service. As Senate Majority Leader, she oversaw the passage of historic and transformative legislation on a wide number of issues, including voting reforms, gun safety, women's rights in healthcare, immigration and dreamers, the LGBTQ community, the justice system, and sexual harassment in the workplace. Additionally, the Senate majority under her leadership passed the most comprehensive and aggressive climate change legislation in the nation and the strongest tenant protections and affordable housing package in state history. Majority Leader Stewart-Cousins, thank you for taking the time to join us this morning. We are absolutely thrilled to have you with us.
And it is an absolute pleasure to be here with all of you in this very, very important conference. So again, I just want to thank you for inviting me to speak to the health plan community. This pandemic has put a strain on our healthcare system that we continue to see as we fight the Delta variant. I'm so deeply thankful to all of our partners in the healthcare industry that have shown up every day to fight this pandemic. As we look ahead, we know that we cannot move backwards in our healthcare system. Our job as legislative leaders will be to ensure we're doing our part to make healthcare more accessible and improve transparency. One of the ways we've done this is through expanding access to telehealth services. In the 2021-22 state budget, we passed legislation that expanded where patients can receive healthcare via telehealth and where providers can deliver care via telehealth. In addition, this legislation provided the state a significant cost savings while allowing providers to deliver care anywhere within the United States and its territories. Now patients are no longer restricted on where they need to be in order to receive care via telehealth. Our priority has remained to make healthcare more accessible and affordable, and that's why in the 2021-22 state budget, we passed legislation that required the essential plan to cover dental and vision services without any cost sharing or co-insurance requirements, in addition to the traditional medical service that it already covers. Additionally, it eliminated the $20 monthly premiums that are currently imposed on those with incomes between 150 and 200% of the federal poverty line. Now, all New Yorkers who are eligible for coverage under the essential plan will not have to pay a nickel for the medical coverage that they need. This will ensure that low-income New Yorkers who do not qualify for Medicaid or Child Health Plus will continue to have access to quality healthcare regardless of their financial circumstances. There's a saying that we have all heard often: when America catches a cold, the Black community catches pneumonia. We've seen this pandemic highlight the inequalities in our healthcare system, but it's renewed a push to close the gaps that do actually exist in healthcare access. Last year, we held 2 public hearings to assess the disproportionate impact this virus has had on our state's minority communities. From those hearings, we were able to put forth legislation and find partners in the community to ensure that we are best helping New Yorkers. As we look forward, I recognize that some of our best partners include our federal representatives, and I'm committed to working with our partners in Washington to push for critical funding in this area, as well as others. The rising prescription drug prices have been devastating to New Yorkers who depend on prescription drugs to keep them healthy. The Senate majority is committed to finding ways to curb the increasing cost of prescription drugs. One of the ways this can be done is by increasing manufacturer disclosure transparency, as well as regulating pharmacy benefit managers. Finally, as a conference, we are constantly refining our vision of what healthcare in New York could be and the best ways to provide coverage for all New Yorkers. This includes looking at single-payer healthcare. The Majority Conference is engaging with a wide array of stakeholders, including the health plans, to get feedback on the current state of New York's healthcare system, to identify ways to increase quality and access, and to develop options to decrease the number of uninsured. Issues such as benefit coverage and financing are being studied in order to ensure that any possible single-payer system does not lose the quality of care, including timeliness of appointments and services. The health plan industry has experienced many of the same challenges faced by those on the clinical front lines of this pandemic, but has faced unique issues of their own. Work hours and environments have also changed. There were and still are shortages of professional staff in your industry. Stress piled up and mental health status has declined. But this area of the healthcare sector has faced some of the most broad and longstanding mandates from the state. Your flexibility has ensured that many New Yorkers have not had to take on large bills for COVID-related vaccination, testing, or care. That has saved lives. We know that the road to recovery is long, and we will have upcoming challenges in our next legislative session, but our state's residents expect leadership and action from their government. And we will continue to work with Governor Hochul to confront this crisis and help struggling New Yorkers. Healthcare is essential to our communities, and we will never forget your service to New Yorkers during this pandemic. Thank you so very much, and have a great conference.
Well, thank you, Majority Leader Stewart-Cousins, for your insightful comments, and we appreciate your ongoing leadership on these important issues in healthcare. We look forward to working with you and your colleagues in the upcoming session on measures to improve the quality and affordability of healthcare in New York and to ensure that the system is equitable and accessible to all New Yorkers. With that, I just want to thank all of you again for joining us today, and make sure to stick around for our opening panel of today's program, The Healthcare Outlook Beyond COVID-19.
Good morning. Thank you, Eric, and good morning to all the attendees. My name is Michael McGuire. I'm the board chair of the HPA board, and I'd like to welcome you all to this year's annual conference. I would echo Eric's comments in thanking the Senate Majority Leader for offering her comments this morning. I think they're very insightful as we look to these next 3 days, and we are all aligned and looking to do the best we can for New York and all of its residents. I'd like to also just say to all of you and your families that I hope everyone is healthy and safe and doing well. HPA's annual conference is one of the many policy forums HPA hosts each year in an effort to generate discussions and engage others in the healthcare industry on what we can do to promote affordable, safe, and coordinated healthcare that is really grounded in the best practices. Over the next 3 days, It is one of the many policy forums that we'll be hosting. We'll be talking about, we'll have experts joining us from both state government, academia, and the healthcare system. And we're going to ask for those folks to provide us with their perspective and insights to things like, what does the healthcare outlook look like beyond COVID-19? How do we address the racial and ethnic inequities in healthcare, which is really imperative to all the actions that we're taking? The role of technology in this post-pandemic era, efforts to contain healthcare costs, which is important to all of us, and the role of transparency in transforming the healthcare system. I look forward to these discussions and want to thank HPA and their team in putting this year's conference together. With that, I'm going to turn it back over to Eric, and he'll walk through some of the features of our virtual conference. Thanks, Eric.
Thanks, Michael. Now, before we get started, I want to thank all of our sponsors who helped make today possible, especially our presenting sponsors, DentaQuest, Avisis, and Cognosante. Without them and all of our sponsors, we wouldn't be able to make this program possible. We also have a great sponsored session today at 11:30 by Avisis that you won't want to miss. I also want to thank our exhibitors and ask that you take a few minutes over the course of the next few days to visit with them. Simply click on the exhibitor booth tab if you're using the your phone app, or if you're on your computer, it's located on the left-hand side of your screen. Now, just like last year, as an added incentive, we've incorporated a great gaming challenge. You'll be able to participate by submitting the code for the various challenges. And for some of these challenges, the code will be an answer to a question. Other challenges will require that you set up meetings or request information from some of our exhibitors, who will then send you a 4-digit code that you can provide as part of the game challenge. Also, the game challenges can be found in the daily announcements. Now, at the conclusion of the conference, the top 3 point earners on the leaderboard will win some really great prizes. First place will receive a $250 Amex gift card. The second point earner will receive a $100 Amex gift card. And the third will receive a $50 Amex gift card. So in order to access the panel discussions over the course of these 3 days, make sure to return to the agenda and click on the link to each session, as each session has a unique link. Now, if for any reason you might experience technical difficulties, we do have live tech support who will be available throughout the event, so just click on the live help desk feature. Finally, I'd like to thank the HPA team for their hard work on the conference and their hard work every day on behalf of our industry. And of particular note, the hard work that went into putting together this year's conference. I just want to extend a special appreciation to Arlene, Ashley, and Kathleen for their hard work in helping us get this off the ground to ensure that you all have a great conference experience. With that, I'm excited now to turn the session over to Michael, who will introduce and moderate our first panel of the day.
Great. Thank you, Eric. It's my pleasure to introduce our first panel and to moderate the discussion that will examine the healthcare outlook beyond COVID-19, including reimagining what the healthcare delivery system can look like, measures to contain costs, and an effort to address all the health inequities. We're going to start with this session with a presentation by Ruchita Kewalramani. Ruchita is the Managing Director for Strategy Enterprise and Value Health Services at PwC. In her role, Ruchita serves as a principal in the healthcare payer, provider, corporate, and business strategy. Ruchita brings an extensive experience and depth of knowledge in the private health insurance sector through years of experience in helping health plans develop growth strategies, clinical portfolio design, digital health strategies, consumer engagement models, and for both medical, pharmacy, and behavioral health, and also designing advocacy solutions. Also joining us today is Meeti Tu, the Executive Deputy Superintendent for the Insurance Division at the State of New York DFS, where she oversees the regulation and supervision of the life, property, and casualty and health industries for the state of New York. Prior to joining DFS in January of 20, Meeti was a partner at Debevoise & Plimpton's Restructuring Group and Global Insurance Services, where she oversaw the regulation and supervision of, she was engaged with both working with insurers, reinsurers, pension funds, private equity funds, and other capital providers in a wide range of transactions and restructuring matters. Our third panelist today is Louise Cohen. Louise is the CEO of the Primary Care Development Corporation, PCDC. It's a nonprofit community development financial institution dedicated to catalyzing excellence in primary care through strategic community investments, capacity building, and advocacy to achieve health equity in our diversified communities. Prior to assuming the leadership role at PCDC, Louise was the vice president for public health programs at the Public Health Solutions of New York City, and before that held successful leadership positions in the New York City Department of Health and Mental Hygiene. More information about our panelists can be found by clicking under their names. Unfortunately, today we had another panelist, Angela Profeta, who was the Deputy Secretary for Health for the state of New York and the office of Governor Kathy Hochul. She was unfortunately unable to join us today due to a last-minute conflict. But with that, I think we have a great panel here today. And how I'd like to open it up is I'm going to turn it over to Rachita, and she was going to walk through a presentation on what we see as the upcoming costs in healthcare. Rachita?
Thank you, Michael. Pleasure to be here today, and thank you for having me. I'm going to talk through a little bit about the report that, what we call behind the numbers report. What this is it projects out and talks about healthcare medical cost trends. So when we think about the employer-sponsored insurance, which is about 160 million, 270 million people across the US who get their insurance through their employers, employers do projections in how they think healthcare costs will be in the upcoming years. So what we have here, what you see on the screen is behind the numbers 2022, which is a leading sort of publication out in the industry that we've done, a 16th annual report for us PwC, among a series of reports that we do that talks about leading drivers and dampeners of healthcare trend, referred to as inflators and deflators in the report. Just in terms of the research itself that went into this, there were three major inputs. First is interviews with health executives themselves. HRI, which is Health Research Institute that is with PwC, conducted about 31 interviews between February to May of 2021 with healthcare executives, which includes plan actuaries, underwriters, overseeing about 90 million employer-sponsored lives and executives from these employer coalitions as well. The second input that went into the report is just a proprietary survey that we did, which included employers, so health plan employer executives who are responsible for designing benefits for their employees, clinicians themselves. We surveyed about 1,300 clinicians who oversee cost trends, utilization of services across the country, and then other sort of providers, pharma life sciences companies and executives across each who oversee how things are trending within healthcare. And then finally, our own analysis of government, data sources, journal articles, other publications that we bake into things that are available to us. If you jump to the next slide, what you will see here, just from a headline, perspective, we expect the healthcare trend in 2022 to be about 6.5%, down from 7% in 2021. That is largely rooted into pandemic inflators and deflators. As you can see, right, the 6.9 is higher than what we had observed in 2016 to 2020, but lower than 2021 itself. It is a little bit more nuanced in how and why plans as well as employers are projecting this for 2022, but we will get into it a little bit. So just, at a headline level, that's the projection we are placing for 2022. This takes into account self-insured employers, so employers who are bearing the risk themselves, as well as fully insured employers who buy sort of, off the shelf or custom design premium-based products for their employee base, but are not the end risk bearers. Health plans as well as employers take a variety of factors into account, starting with historic claims. So what has their experience been over the last few years? And then normalize that to create a baseline of claims data that they start to believe into, and then any kind of impact in terms of specific conditions, specific drug prices, plan design changes that they are making, using really that sort of analytical approach to projecting out where they think the cost will land. If you jump to the next slide, like this slide makes it believe there was no pandemic, that healthcare costs have been increasing about 6 to 7 or 5 to 6%, 7% year over year, but that's actually not right. So when you see this particular chart, you will see that in 2020, 2021, the healthcare costs have been way below projections from where it was historically. And there are a few different factors that went into it. 2020 was the year of the pandemic. We saw lower utilization due to the pandemic itself. So there was a lot of, there was deferred care and things that prevented consumers from getting access to care as well. There were a lot of access barriers as well. Going beyond 2021 into 2022, you will see that the lines merge and we are starting to see same utilization patterns as we did prior to the pandemic. On the next slide, we now talk a little bit about the inflators and deflators. So there were 3 particular inflators that we see going into 2022. The first one is the COVID-19 hangover, what we are calling it, that leads to increased utilization. And there are a few different factors that go into it, but this particular one has the highest impact on medical cost trend. The second inflator of medical cost trend is just health system that has prepared for the next pandemic, investments that have gone in, increased access that we are starting to see through health systems. So some of that will continue to, sort of pull in more utilization of services, which in turn impacts medical cost trend. And lastly, just, digital investments to enhance patient relationship and increase in utilization. There were 2 particular deflators that we project into this medical cost trend as well. The first one is consumers leaning into low cost sites of care. We talked a few minutes ago, right, that, that the access issues in telemedicine, tele-mental behavioral care, some of those things have been removed. So consumers are leaning in and utilizing care much more digitally, as well as other lower costs. So, the traffic that we saw in ER utilization or urgent care has now started to shift more to digital channels, as well as other places. And then the last sort of deflator is health systems find ways to provide more healthcare for less. So just the system changes that some of this, like more shift towards primary care, more shift towards preventative care. We are seeing the health system find more ways to engage those consumers as the hospitals have been busy with a lot of COVID related care. So some of that is also we're starting to see that being much more sticky, which in turn will have a downward trend on medical cost. On the next slide, like the first inflator, which was the COVID-19 related hangover that leads to increased utilization. This has a 3-piece sort of framework. The type of care, which foregone care in the past 2 years, we know some of that is not coming back. Just annual preventative visits, diagnostic, lab imaging, those kind of things, even surgery that was sort of not too invasive has been taken care of. And some of those things in terms of utilization of services for foregone preventative care will not be coming back. However, deferred care may come back in the same form and at the same levels. Those things include knee surgery, sinus surgery, other non-urgent but necessary procedures that we do think will be coming back in 2022, which will have an upward trend on medical cost. And then lastly, the biggest upward impact that there is deferred care that requires more intervention now. So when you think about the, like the employer population, a few biggest drivers of cost for them are cancer care, diabetes, women's health issues, fertility, and those things. Those conditions, because of lack of screening, have worsened. So, things that we see, cancer care that we may see in the coming year, maybe stage 3 could have caught at stage 1. Should some of the screening had happened early on. So, or pre-diabetes worsening to diabetes and other things like that. So that's where those conditions that have worsened in the last 18 months may come back with requiring higher levels of care and have higher levels of acuity that's going to have much more sort of negative impact on medical cost trend. On the next slide, we then get into digital investments that enhance patient relationship, increased utilization. Many, I think one of the studies we saw was that we conducted that 40% of the utilization for preventative services and wellness visits in the pandemic year were through digital channels that included consumers that had used digital channels for the first time ever to receive care. Now, we went on to further survey in how sticky some of these digital channels will be. Do consumers start to find comfort in telemedicine, telepsychiatry, sort of behavioral therapy visits, other things? And we are seeing a lot of comfort around consumers who otherwise would have delayed walking into the physician's office, now seeking care through digital channels. So we think some of this will be sticky and will have continued upward impact on medical cost trend. On the next slide, investments, sort of another deflator. So consumers leaning into lower cost sites of care. So willingness among consumers with employer-based coverage to use site of care compared to their average cost claim, right? So in-home clinician visits, urgent care visits, retail clinic visits, and video virtual care visits have continued to see an increase. And when you compare these sites to an ER or walking into an urgent care that is not in network for the consumers, these generally hold a lower cost. So we are starting to see stickiness and much more utilization from consumers into lower cost sites of care, which overall has a downward impact on medical cost trend. So with that, I want to wrap up this piece of the presentation. Thank you again for having me here. Hope this was insightful, and congratulations and best of luck for the next 3 days of the conference.
Thank you, Ruchita. It was very, very insightful. You would really think about, 2022 and trend and predicting trend. It really is something like we've never seen before, right? We come off of 2019, the highest utilization we've seen in the commercial space. 2020 hits, everything kind of gets turned over. We're figuring out 21 now, but really what happens in 22, there are so many moving parts as you just outlined there. It really is, it's an actuary's dream, I guess, right? To try to figure this out and predict this. But as the folks, as part of the panel, we've got to figure out what's next. So my next question is for Miti and for Louise. So what we've just seen really, and what Ruchita just went through has been unprecedented, right? We've seen, the deferral of care, COVID-19 costs like we've never seen before. We really need to think about, what's going to continue, the increased behavioral health and access, which is a good thing, right? That we have access to that, but it doesn't change the dynamic a little bit. So when you think from your perspectives, and Miti, I'll go to you first, so what we've seen, and what are the changes and the new approaches that have been brought through the pandemic that you'd like to see continued as we go into 22 and beyond? And then Louise, I'm going to ask you the same perspective.
Well, I mean, first I'd like to say to your comment about this being an actuary's dream. I will pass that on to my colleagues. I mean, it's been a challenge for all of us to analyze the trends. And as Rashita's presentation made clear, they go in different directions and we have to make sense of them. You know, as you know, when we think about certainly rates, we think about long-term impact. And I think it's fair to say it's hard to know yet for certain, you know, where things are going to go. We're seeing claims return to normal levels, but we know that also means that premiums are going to continue to rise faster than we would like, and that's something that we need to be focused on. You know, we have seen subsidies, and Senate Majority Leader Stewart-Cousins mentioned that, but those, you know, may not last forever. So we need to continue on costs. In terms of approaches we'd like to continue seeing, I mean, obviously technology has been a big driver, and we'd like to continue to see that. We obviously are keeping a close eye on the long-term impact of telehealth and other technologies, with the potential increase for utilization, et cetera. Something that's been mentioned briefly earlier was staffing shortages. That's also something we are focused on. And what does that mean in terms of costs? And obviously inflation is a big issue.
Thank you. And Louise, before I turn it over to you, I would ask the attendees, please join into the chat box. If you've got any questions you'd like me to introduce to the panel, I'd be happy to bring them up and continue our discussion. So Louise, your perspective on sort of what you'd like to see keep going?
Thanks for having me at this great conference and to join this great panel. You know, I think that, you know, I really care about what's happening in the primary care system. And I think what we've seen there is a little equivocal. Much of primary care really was left out of the early COVID response. And you could imagine if we had been able to really activate primary care in the early part of the pandemic, I think that there would have been potentially less impact on the hospitals, particularly in the emergency rooms and even in urgent care. And that was true for COVID testing. That was true for sort of early identification and treatment. But I think some of the things that we learned through this pandemic is, first of all, we really learned that you can change the regulatory framework on a dime. And I would love to see a lot of other regulatory issues at New York State level and other levels to really be sort of begin to think through how we could move much faster to change things, whether it's about siting or a physical plant or a whole series of other things. So really appreciated the fact that the state moved very quickly to change some of the regulatory framework, and particularly around telehealth. I think telehealth is a great example of the things that both are terrific and then bring with it some challenges. So I think for a lot of people, telehealth, whether it was telemedicine or telepsychiatry, it really was a lifeline, and that was really important. But what it doesn't do is, for example, we've learned over the last 5 or 10 years that primary care is really best done in a team-based approach. So you have not only a physician, but you have perhaps a psychologist and a social worker, and you have a nutritionist, and you have a nurse doing medication management, and that all happens as one person walks into a primary care site and then is able to access a lot of the other services that are there. And telehealth, it's very hard to do that. You end up with very discrete activities. And so I would think that that's one of the things that we may want to not reconsider whether telehealth is important. Certainly, we've learned it is. But I think we need to think a little bit about what's needed on site and really what's needed, what can be best done in a telehealth modality. And so I think the other thing I was really interested in, thank you for that great presentation, Rashita. I think that one of the things you said was really interesting, that consumers are leaning into lower cost sites of care. And that's something that I think, again, it provides access when you have a lot of retail clinics or you have urgent care available to people. But what it really is, though, is episodic care. It is not long-term. It's not a relationship with a primary care provider who really knows you. And so I think while we really need those access points, we need to figure out a better way of tying them all together so that the primary care provider really is informed of and knows about those other activities, and then can really do the work that they need to do for coordinating. So I guess I would say a lot of the things in the pandemic had both a positive side and then potentially a cautionary side to what we think about the long-term health of people.
Thank you. I think you're right. And I think, Miti, I do need to correct that. I don't think it is a actuary's dream. It may be their worst nightmare. But either way, I've got a couple of buses already on. I described it incorrectly. But so think about that, right? And we look at, okay, what's coming over the next 3 to 5 years? You know, we just went through that. What did we learn? What do we think else is going to be driving those 3 to 5 years? You know, as we, we come out of this and we look forward. And we've mentioned a couple of things about telehealth and sites of care. But Rachida, I'd appreciate your opinion on what do you think is next, or what are those other drivers we should be looking for?
Sure. I mean, Louise made a great point. There has been a lot of investment in primary care. It was a little bit out of focus the last 2 years, but it is coming back into focus, especially when you think about, like building a care team that is physical and digital in nature together. So we are seeing a lot of models and investments being made around how do you manage the cost of care with a physical and digital integration, to the point that, right, like digital cannot be the entire thing. Physical, there is capacity limits. So how do you blend the two together and create care team around cohorts of member that includes and meets the needs that they have? We see a lot of investments around cost of care management on mental and behavioral health as well. So, the population across generations have seen a lot of stress in the system, seeing loved ones being stuck in a different part of the country, not having sort of the ability to meet your family, your friends, all those things, including, like not being able to meet your colleagues, having to work remotely. All of that has caused a lot of stress in the system. Some of the stress being just more sort of social in nature, some of the stress also being financial in nature. So another piece and evolution that we're starting to see is a lot more focus through employer as well as sort of other sponsored lives on behavioral and sort of mental health issues, really top of the agenda for a lot of health plan executives, employers, and other pieces of the community. So we're going to continue to see some investments across those as well.
That's good. I think it's helpful. Michi, your opinion on that, your thoughts on that, the next 2 to 5 years?
Yeah, sure. Thank you. I'd like to build on a point Louise made earlier in terms of, we've seen during the pandemic that the regulatory framework can move fast sometimes. We've also seen, I think, a great example of all of the stakeholders in the healthcare system coming together to make sure that it worked in a period of, incredible stress. And I think one lesson is that we really need to continue to do that to address, beyond the pandemic, some of the challenges that existed before, but that became very painfully clear during the pandemic. And this was mentioned before, but the pandemic really highlighted deep health and economic disparities in our society. How the pandemic has disproportionately affected the poor and other disadvantaged communities. And so, that is something, a lesson is we need to continue working at this and work harder, because evidently what we've been doing to date hasn't worked. I know we'll be talking more about that, but I think that's one of the big takeaways and lessons for the next 2 to 5 years.
Thank you. I think that's spot on. Louise, thoughts on that?
Yeah, so I think I want to go back to, again, sort of thinking about what could potentially be a primary care anchored system. I mean, we've really talked a lot over the years about sort of the high costs in healthcare. And the real way that I think that we can manage that ultimately is to focus on building the most robust primary care system that everyone has access to really think about reducing any barrier to primary care whatsoever, because primary care is the only part of the healthcare system that has been shown to reduce all-cause mortality, reduce morbidity due to sort of neonatal and maternal morbidity, whether it is thinking about reducing hospital and emergency room visits, thinking about life expectancy, creating good jobs and anchor organizations and communities. And so for all of that, primary care gets about 5 to 7 cents on the healthcare dollar. And so one of the things that I think is going to be a continuing trend that I'm hoping we'll see here in New York State as well is that there are about 11 states which have introduced legislation or regulation to increase over time the proportion of spending going to primary care, and that can be a 1% year over year for commercial and for commercial payers as well as for public payers. And it can also be setting a target. So some states have set a target to get to 12 cents or 14 cents, which is actually about the amount of the percentage of cost of money that goes to primary care in the OECD countries. So, we think that there's an association between this kind of higher primary care spending and reduced total cost of care. And that's been shown in Rhode Island and also in Oregon, the 2 states that are farthest along this pathway of really dedicating an attention to improving the primary care system. And by that, I think there is a lot of different ways to do that. One thing it can certainly be to increase compensation for primary care, the primary care team, not only primary care doctors, but the team as well. But it can also be for incentive payments or for other kinds of what gets called value-based care, value-based payment mechanisms. And so I think that's my hope is that in the next 2 to 3 years, New York will also adopt this approach where we're really rebalancing the healthcare system, because we've all talked about reducing costs. But the only way I think that we can do to really prove that is to bring in primary care and to really emphasize that, to build primary care centers where there's insufficient care. And I think to the last point that got made, this is a question of equity. This is not just a question of better health outcomes. The communities that were hardest hit by COVID were communities, low-income communities of color, where there were fewer primary care providers before the pandemic, and therefore reduced access during the pandemic and continued today. So we think that that's one approach that we think will help build out the robust primary care system. And I think it's within our grasp here in New York State. It's certainly been shown to work in other states.
That's actually a great segue, because Miti had brought it up and I'd like to go there, but I will add one comment on the primary care position. I think that what we learned quickly when COVID broke was, right, everyone's, trying to figure out where to go, what to do, who to see. And the first thing you heard was, first check with your primary care physician, right? And it's kind of an alert to all of us. You want to have that relationship, right? That's not the day you think you have COVID is the first time you want to call a primary care physician. It really, I think, was a good lesson for folks, for people to say, okay, do I have a relationship with somebody? Do they know who I am, what my records are, so that when an incident like that comes up, COVID or anything else, it drives you back, and hopefully you've got that existing relationship. So hopefully it was a lesson learned for all of us, and the delivery system to make sure that initial relationship's already established. So, and I think we've done things around, continuing that or growing that. But I would like to jump to when we talk about inequities, and I think you're absolutely right. We've seen the Black and Latino New Yorkers have really suffered disproportionately through this pandemic, right? They've had a higher magnitude of cases, hospitalizations, and deaths, a larger financial impact. So, as a community of all the folks here today on the phone, thinking about what can we do better to promote these, and address these disparities and promote race equity in the healthcare system. So, Rachita, I'd like your opinion on that, your thoughts on that, and then I'm going to turn it over to the other panelists.
A lot of investments are being made. Every health plan, sort of every employer that I can think about is investing and making sure some of the access issues, some of the cost barriers are sort of, they approach it in a way to make sure that all sort of portions of the base do get enough access. So, some of the things that we are seeing is reduction of that high deductible health plan to certain portions of the population, making sure that they don't carry that burden of the high deductible health plan that prevents them from getting access to services. Some other places we are also seeing certain investments being made, right? So clinics being stood up in certain areas, sort of investments in low cost housing, setting up retail clinics in certain areas of the country where there are access issues. So there is a portfolio of investments that I will say is being made across the system to reduce some of the, inequity as well as inequality issues, removing the barriers to care that are physical as well as financial in nature.
Thank you. Louise, thoughts on that?
Yeah, so I would agree with all of that. I think though that we have to look at two things. One of them I think is is sort of a community level approach. And then I think the other is sort of thinking about the health system approach. So from a community level approach, I think we have to remember that the inequities and deliberate disinvestment actually started well before COVID, right? This sort of everyone who's on this panel, and certainly everyone who's listening in, really understands, I think, that point. And I think a lot of folks outside of the healthcare community are beginning to understand that now. But, historic redlining practices where banks in the 1930s actually carved up, communities and said, don't invest there, you can invest there. And the don't invest there were based on two things. It was based on race, where the proportion of Black people lived. It was very straightforward. And it was based on income. And what's interesting is PCDC did an analysis of New York City, and we don't have any reason to believe that this is untrue anyplace else, is that the places that were redlined in the 30s continue to have the worst outcomes today, continue to have fewer primary care providers today. So when we think about investment, we have to actually think about deliberate investment. And that really means saying, not just there's going to be equality, that there'll be as many primary care providers in disinvested communities than there are in wealthier communities. But I would argue that we actually need more primary care, more access points, more access to specialty care that really would make, I think, a big difference. And so one of the things that I would hope is that organizations like mine, which has a capital lending component of what we do, as well as a sort of technical assistance improving care component, that we'd love to partner with the healthcare community, certainly the insurers, to think about, let's see, we know where those communities are. Let's work together to try to make sure that we can build those access points really that are needed in those disinvested communities, which really are completely based on race and income. So I think that's a key partnership that I think we need to have. And along the way, as we're thinking about that at the community level, then I think we want to say, okay, well, we need primary care. What else do we need? What does the housing stock look like? Where's the fresh food availability? So that we're thinking about sort of broad investment in a community. And I actually think that the health system and health plans, large health systems, need to help provide some of the capital that could make those things happen, but they can't be the only ones, right? We have to work with banks and other community development financial institutions like mine and others to really develop those community plans that I think really make a difference.
No, I think you're right. The investment's got to come from a lot of different places, right? I mean, because the social determinants of health really are, we know it drives cost, right? And we know that, to refute it to your point, where are we making investments in that? Really, short-term and long-term, not just because of COVID, but what we saw before, and continue with those investments as we go forward. And you also did touch on, Louise, a little bit about, value-based programs and payments. And I know that New York is thinking about that. Other states are thinking about that, because that will be, I think, a good avenue for to continue development in those areas, right? To partner with the provider community, with everyone with the same goal, particularly around those inequities and those social determinants of health. Miti, I know this isn't your, you like to play in the commercial world. Would you have thoughts on that or ideas?
Yes, I do. First of all, I want to agree, or echo all the comments that have been made. I mean, I really don't have anything to add there, but I thought I'd touch on three areas that we at DFS have been thinking about, and I do think they have a relevance for this conversation. One is, as you all know, DFS has been focusing on the diversity of the leadership of our regulated entities, boards, C-suite, across the insurance sector, but including health. And there are many reasons for that, but I think a conversation like this really highlights, it's just one example where having that diversity of views, of perspectives into this complex, long-standing problem is more critical than ever. Louise talked about the importance of having multiple stakeholders be invested. That's true, I think, within each of the organizations of each of the stakeholders that should be invested. So I did want to make that point. A second point that, again, across the board, we are focused on, and including in healthcare, is the need for good data, more data. Who's getting care or not, what care. I think that's critical for a bunch of conversations, including tackling the issue of cost, but also this issue. At the same time, there are some complicated debates around insurers and regulators collecting more demographic data on who is getting care. And these discussions are happening, certainly in the regulatory community. That should not be a reason to not do anything in this area, but that is a very important part of the conversation. So the need for data, anecdotal evidence is not always the best way of doing policy. And the last point I will make, which I think you all know, as a department, we've been focused on climate change and risks relating to climate. We actually just issued yesterday our final guidance to New York insurers on management of financial risks of climate change. So why is this important to this conversation? It is well documented that climate change has an impact on human health. It is also documented that vulnerable populations suffer disproportionately from that. And so as we think about health inequities, I think keeping the environmental considerations in mind is very important. And I think that's an area where on in the health plan community, it is, not always top of mind. And that's something that, I would encourage all of you to, include in this conversation.
That's, thank you. That was very, I think you're spot on, right? I mean, all three of those pillars or issues really drive a lot of things, right? They drive cost, they address the inequities that we see out there, and they're both costs of today and in the future. So I appreciate that. Let's switch a little bit and think about technology, right? So we hit upon it a little bit around telehealth, but COVID brought a whole new world, right? We had this telehealth ability beforehand, quite frankly, very underutilized in the commercial space. And then 2020 comes, and then whether the utilization goes up too, the technology gets spread to more practices, more gets more available, more access. So that's good for everybody. But let's think about technology, beyond just that. So what do you see? And I'm going to ask each of you this, where do you see investments in technology? What type of technology? What other tools and strategies do you see out there that we should be thinking about? Things like artificial intelligence, but what can we do? What's out there that we think can ultimately, again, address what we've talked about, the cost, diversity, and inequity, and really just supporting better patients and our, the folks that we're looking to support in the marketplace, and whether it's government programs or in commercial. So Rachita, I'll go to you first. So you're lucky you, but give me your thoughts on the future of technology.
Sure, absolutely. I mean, technology is top of mind for every health plan executive that you can imagine today, right? So it is a topic that is all the way top of the agenda. It does take a lot of mind space for every health plan executive, employers, sort of even consumers. So As I think about the, out in the future, what are some of the investments that are being made into technology? I think of two specific areas where these investments are being made. The first one is just generally elevating the experience that consumers of healthcare get in using technology. So some of the examples that you can think about is care on demand, linking information across systems, providing an elevated experience to the consumers through better website design, through better applications, through being able to book appointments online, through a better scheduler, through being able to cost compare and know the cost before they get into a clinician's office, right? So all of these things, including better better use of AI, better data analytics that Michi sort of touched upon, that elevates the experience that a consumer of healthcare gets. And there is, there is a layer of experience that consumers get through what they see on the application or the website, but there are a lot of things that go under it to make it happen. And we're seeing a lot of sort of consumers demanding better experience, because as they use sort of applications, websites, and have interactions outside of healthcare, that really sets the bar real high. And so that is somewhat bleeding into healthcare. And, there is a lot of investments into better experience and hopefully better outcomes, because you don't abandon an appointment or things that you're not otherwise able to figure out. You actually make it all the way through because you get a better experience using these technologies. So consumer experience has been top of mind for sort of a lot of folks that I connect with. The second I want to say is just digital value creation. I know it's a buzzword in the industry these days, but as you think about across the spectrum and sort of clinical operations at a health plan, at an employer, and other sort of sectors of the industry, taking tasks that are otherwise manual, strenuous, repetitive, and digitizing those and creating capacity in the healthcare system. So digital value creation through digital operations, digitizing things that are otherwise manual in nature has also been sort of a big area of focus when it comes to technology investments.
I think you're absolutely right. I think the consumer experience that we're all used to, whether how you shop and how you find out about a restaurant, but in the healthcare industry, I think we've got to raise the bar to get there. And I think consumers now recognize you can do it in other sectors. We want to see it here. So, and I think your point around data, right? Michi, you brought up data before sharing, but I mean, it's data within the provider community itself, and getting that data access to the member themselves will really raise the experience and hopefully raise quality. Louise, your thoughts around technology?
Yeah, so I think we have a little bit of a cautionary tale here. So electronic health records, right? They were, going to revolutionize everything. They were going to provide all the data that we need, and they are even today. The second generation, maybe third generation EHRs that we have are incredibly burdensome for the provider, right? The amount of time that the provider spends, facing the computer versus facing the patient is actually quite substantial. And while it has actually enabled us to do much, and I, think it's a great, the great invention, it actually, interestingly enough, a lot of practices have gone to a medical scribe who is in the room with the provider, actually taking the notes for them, because it's complicated and the provider can't, spend the time with the patient. So I think we want to make sure that the technology is either really changing the life of the consumer, as you point out, or changing the life of the provider. And so I would say there's some things that we actually need to do that are basics. And maybe these aren't the sort of, AI kind of cool new toys, but think about remote monitoring. I mean, I think for a lot of folks, if they had basic remote monitoring of their diabetes, their asthma, their blood pressure, those are basic things that I think would make a big difference. But those require that the technology is thinking about those very basic elements, right? And that's not what most of the sort of new technology providers are really focusing in on. They're thinking about predictive analytics and those kind of big picture things. So from the consumer point of view, I think we have to remember also there is a digital divide. Even though people do have an experience and they do have, many people do have smartphones, there's still, as we learned during the pandemic, a lot of folks, places where they don't have cell phone access. where broadband remains a problem. So having actually the ability to, to tell your provider what your blood sugar is doing, or to basically send that information, like that would be very valuable to the consumer and to the provider. So I think that there's an issue that we have to sort of make sure that some of the, the sort of, huge amount of money that's going into technology development around health really starts thinking about the basics. I think the only way that that's going to happen is if there is some emphasis placed on that by government and sort of support for that. I think from the provider side, I think it remains, I don't know, we get pitched, 3-4 times a week by someone who says, I've got the solution to everything. It's push a button and you're going to have all the information you need to know to manage your patient panel. And I wish that was true. But I would argue that we actually need something that provides providers with that kind of, that ability to manage their whole patient population. And I would say, for example, all the insurers, and we think this is great, provide providers with sort of post hoc gaps in care report. But really what you need is that at the point of care, right? And you need it, in fact, before the point of care. So you need to have that on a regular basis, so you can begin to call people in, and you actually need that at the point of care, so that when someone is in your office or on the phone with you at a telemedicine activity, you can actually do something about it. So I think we need to start getting to this prospective moment, but we need to do it in a way that actually facilitates the true working life of a provider, as opposed to sort of the amount of attention that's, I would argue that we want to do the big picture, sort of predictive analytics, sort of, AI kinds of things, but this sort of segment of the technology world is really lacking. And I think that's a really important place that we need to focus our attention on.
Thank you. I think you're right on there, and particularly, right, there are lots of investments going into technology. AI is the buzzword, and but things like remote monitoring and devices, they will help. Where is the investment with those, and engaging with the consumer, right, and connecting that back to the doc. So all important, lots going on. Miti, ideas there?
Just to emphasize maybe the word of caution that Louise shared, I will call it a regulatory speed bump as companies, fully embrace technology, AI, whatever it is. I think what we're seeing across the board, again, not just in healthcare, is, it is the buzzword, people and companies promising, miracle systems, processes that is gonna, do everything better, more cheaply. We're at very early stages of, developing, particularly, the AI forms of technology and their applications in, the financial services, including insurance, including the healthcare space. So, we on the regulatory side are obviously looking at, what we need to do to support the industry's embrace and the responsible embrace of these technologies. Going back to our discussion about health disparities, I think one of the big concerns about some of these tools, not the digitization, but really more of the artificial intelligence, machine learning tools, is that they have a real potential to reinforce existing inequities as opposed to actually helping, remove them. And so the word of caution is for companies looking at, these promising new tools, is to really embed in that process a focus on potential bias, discrimination, et cetera, And we on the regulatory side and the regulatory community, we are all talking to each other. This is one area where regulatory consistency is going to be critical. There have been some efforts by certain jurisdictions to try to come up with a regulatory framework, but we're really still at the beginning. This is a conversation we welcome having with, all the plans and the other stakeholders who are looking to make investments and to deploy these technologies in their businesses. But I would just say we should all move carefully, make sure we're not, creating problems for ourselves and instead of just solving problems.
Very important, and you're absolutely right. That's the as we look at all these investment, all these tools, but we've got to make sure that we're going back to the foundation of what are we missing, right? And, and make sure that that doesn't just, keep going in the wrong direction, that it looks at the entire community. So you're absolutely right. So we've got about 6 minutes left. So we can't leave a conversation about healthcare without talking about healthcare cost, right? So, and lots of drivers there, and Rashida, you did a good job of kind of, expanding on some of that in the beginning, but should the folks on the phone, right, or the attendees today, and, through the government and the marketplace, what's your takeaway for them? You would like to leave a message with us around what can we do about costs? What are a couple of those fundamental things? I know we touched on them in pieces, but as we wrap up, and Rashida, I'm going to go back to you first. Your thoughts on cost and what can we do as a collective community around ultimately looking at the cost of healthcare and making sure it continues to be affordable and accessible.
Sure, absolutely. I will touch upon what Louise mentioned, that identifying and having a relationship and a PCP, sort of a primary care physician for yourself, is at the heart of how you live a healthier, more informed life, right? So I think just that PCP relationship, and through so many studies, we found even folks who have good access to and can afford PCP relationships do not actually invest into one. So I will start right there, that actually having a primary care physician over the years, building relationship, treating them as sort of your first point of contact for all your care related questions is crucial and important to sort of some of the early interventions, early screening. So that would be second part of my response to you, that your annual physical wellness visit, early screenings, all of that goes a long way into preventing having a big bill and a sort of big burden towards healthcare in the end. So those two pieces would be my response, that actually having a PCP and a relationship with a PCP, and second would be engaging in the system periodically, getting all the screenings in, goes a long way in terms of managing the healthcare spend for an individual.
Agreed. Thank you. Louise?
Well, my work here is done. I think you just did
we all have a PCP and we're all getting our screenings.
The brilliant, primary care answer to that. And so I guess I would elaborate on that, which is, I think we need to move the payment system to, we've talked for many years now about trying to move away from paying for visits to really paying for outcomes. But really this is the only part of primary care is the only part of the system where we make people prove the outcomes before we're willing to pay you. And so I think that we have to think about how we start paying on a per person basis, a prospective payment to primary care as opposed to a retroactive payment. We really need to say there's a base payment, and maybe there's some volume there, and certainly there's some risk adjustment that needs to happen. But I think that we need to start paying prospectively for primary care, and we need to do it in a global way. So the primary care providers who might have 7 to 10 contracts really are not having to chase the dollars. And that would have been one of the things that made primary care have to shut down in many places around the country, particularly the smaller providers, the independent providers, was because they were being paid on a per visit basis. And so their income plummeted to some people lost up to 50 to 90% of their income during the first parts of the pandemic. That would not have happened. And there would have been a very different approach to providing some of the necessary primary care if in fact there had been a prospective per person payment where they would have known that they would have had a steady income. And so you need not only the people, the consumer, as Rashika sort of talked about, you need not only the consumer to have a primary care provider, you need enough primary care providers in order to actually to see the people that need to be seen. And one thing just to remember is, we're not out of the COVID pandemic yet, but remember there's a lot of people with long haul COVID. And so that the need to take care of people with long haul COVID is going to fall largely to the primary care system. And the primary care system, which is currently stressed, underpaid, and burned out, is going to need a lot more primary care providers. So all of that seems to me that we have to sort of begin to rebalance the payment system to sort of catch up to where people are actually going to be needing to get their care in the next period.
Great. Thank you. And Miti, you get to bring us home.
Thank you. I'll do it very briefly. I would just hit on two things. One is part of the efforts to address cost drivers has to include more transparency on the cost of care, better and more data. That's a conversation I think we've had with your association and other stakeholders, but that's critical. The other thing is just talking about the broader relationship between the health system and providers and the payer community. We're going to have to work together. There is, an increasing, some have told me, historic levels of, distrust and kind of confrontation among some of these stakeholders. And that's really an obstacle to, addressing some of these issues that we will all need to be part of. So I think, addressing the trust issue, the relationship issue, I think is very important. And obviously that involves everyone around the table. And that is one of the areas that we as a department, are thinking hard about what constructive role we can play there.
Great. Well, thank you. And thank you to all the panelists today. I think it was a very good discussion. I think we covered a lot, but each of you brings a unique perspective. But I think ultimately we're all talking about the same thing. So Rachita, Louise, Miti, thank you very much for your participating today and giving us your time and quite frankly, your experience and your knowledge. So it really, for me, it was a great conversation. I believe the attendees enjoyed it as well. And with that, we thank you very much. Everyone have a safe day. And I'm going to turn it back to Eric.
Great. Thanks, Michael. And I just want to second Michael's comments. This was a great panel discussion. Rachita, Miti, Louise, we really appreciate you taking the time today to be part of this. This was just a fantastic discussion. And Louise, we'll certainly be following up with you following today's program to see if there's ways that we can sort of further the conversation on some of the things that you outlined. At this time, we'll be taking a short break before our panel sponsored by Avisis comes up, which starts promptly at 11:30. That session will focus on the importance of integrating dental and eye care disciplines with medical providers and the role that health plans can play. Just as a reminder, this is a sponsored session, so there's an opportunity to collect points as part of the gaming challenge. And in the meantime, we encourage you to check out our virtual sponsor and exhibitor booths in advance of our 11:30 session. With that, appreciate everybody taking the time this morning to be part of this panel discussion. We hope our attendees found it interesting and thought-provoking, and we'll get started again in just about 15 minutes. So thanks, folks.
Thank you.